All right, I'll be talking about where resistance has been going with FGFR3 inhibitors in bladder cancer. These are my disclosures, and I have to credit GoPro IR from MSKCC to help slides. Erdafitinib, as discussed before, is the only FDA-approved therapy for advanced urothelial cancer with FGFR2 and 3 alterations. It's a reversible ATP competitive pan FGFR3 inhibitor, FGFR inhibitor. The median PFS with erdafitinib is 5.6 months, and both primary and secondary resistant mechanisms are being explored in retrospective cohorts of patients treated with FGFR inhibitors. When we're thinking about any sort of our targeted agents, tumor heterogeneity comes into it, whether it's resistance or even initial treatment. This translational study in Cell Reports was really eloquently done, looking at sequencing at the primary tumor, the metastasis, and also cell-free DNA. Between the primary and the metastasis, it actually found there was about a discordance, about 23% in mutations, in targetable mutations. And when they looked at cell-free DNA compared to the primary tumor, there was about a 17% difference, or 17% actionable mutations that were seen in the cell-free DNA that were not seen in the tumor. So how we're testing and what we're looking at is going to determine when we're going to pick a drug or when resistance develops. And on the right is a specific patient who had the primary sequence, and the metastasis actually had an FGFR3 alteration not seen in the primary, started erdafitinib, and then additional 4 mutations were seen in the cell-free DNA as treatment went on. This is another translational study looking at FGFR3 FGFR inhibitor resistance. 21 patients who received prior FGFR inhibitors were looked at, and 6 had FGFR3 activating mutations, and 1 had an FGFR3 TAC fusion. 6 of the 7 had a gain of 1 additional FGFR3 kinase domain mutation, and 1 patient actually had 3 additional FGFR3 kinase mutations. And that being said, not just a gatekeeper with V555, but also a molecular break with N540. So patients may be developing not just one mutation, or not just one mutation, that type of strategy to target, but multiple all at once. This study also looked at cell lines where they introduced different gatekeeper mutations into urothelial cancer cells and compared it to a FGFR3 TAC wild type. And looked at the IC90 concentrations of all different FGFR inhibitors. It looks like erdafitinib had the lowest IC90, which probably means, and it's the only one that we have currently FDA approved and clinically active. I shouldn't say clinically active, the only one we have FDA approved. And it probably is better than the other ones there at getting past these gatekeepers at dosages. Looking at 2 different patients and making PDX models, they took 1 patient that had a PI3 kinase mutation that was acquired, and when they added just the ERDA or a PI3 kinase inhibitor, it didn't actually get over the resistance. They had to do it in a doublet, but when combined together, they were able to get past the resistance. There was another one that had an EGFR activation. When they looked at sequencing, they actually couldn't find what was going on. In an immunoblotting, they found there was EGFR activation. And when they just did an EGFR inhibitor versus just an FGFR inhibitor with erdafitinib, weren't able to get past the resistance, but also needed them in combination. This is a translational study out of MSKCC. And one of the things that they noted was P53 alterations, which is a common alteration in urothelial cancer. Patients with T53 mutations had a lower overall response rates than the cohort in general, at 22 versus 40%. And 3 of 5 of those patients with primary progression had baseline P53 alterations, and 5 patients who progressed on ERDA acquired P53 in their cell-free DNA at progression. There may be some resistance through variant allele frequencies as well, looking at patients that were likely to progress had higher levels of variant allele frequencies. So for conclusions, mechanisms of FGFR3 inhibitor resistance are varied. FGFR3 second site alterations, bypass pathway activations, pre-existing tumor heterogeneity, and potential others. Incorporation of circulating tumor DNA or cell-free DNA should be incorporated into all ongoing or future prospective trials. And longitudinal collection and real-time analysis of ctDNA to detect acquired resistance and alterations. And improvement on the current available agents, novel agents are being explored that are going to be discussed in this session as well, for potentially overcoming these resistances. Thank you.